Thank you for the invitation and these kind words. It's always a pleasure to come back in England, where I lived more than 20 years ago. So I'm a bit of the outlier here because I'm not at all a chemist. I have only clinical expertise, but that's true that I did some research in the asthma fields over the past 30 years. So this is the outline, I'm going here, of the presentation. I will first start with defining what is a biomarker. And I just took one of the definitions from the National Institute of Health. A characteristic that is objectively measured and evaluated is an indicator of normal biological processes, pathogenic processes, or, and this is important, pharmacologic responses to therapeutic intervention. And I first would like to convince you that probably in asthma the best biomarker that exists now is sputum eosinophils. And I will review with you the evidence for that. Sputum eosinophils is something which is common in asthma, and this is one of our studies in more than 500 patients. When you see that these patients with eosinophilic inflammation, it's a bit tricky because eosinophils is orange when you look at the cytospin, but eosinophilic inflammation in blue here, coupled with mixed granulocytics, are representing something like that half of the patients. So this is a common trait. Sputum eosinophils is something which is reproducible because when you do sputum induction a few days apart in the patients, whichever the technique that we use, plug technique or whole simple technique, you have quite a satisfactory reproducibility of this marker. Sputum eosinophils is related to some physiological disorder in asthma. And you see, maybe you know that the key feature in asthma is bronchial hyperresponsiveness. It means that the bronchi of asthmatic patients are constricting towards stimulus that are ineffective in healthy subjects. And in this quite ancient study, we showed that there was a relationship, not a strong relationship, but a convincing relationship between the extent of eosinophilic inflammation and the magnitude of bronchial hyperresponsiveness. More recently, we looked at the relationship between eosinophils and patient perception, symptoms, rigorously evaluated by the ACQ score. And you see that the ACQ score is linked significantly, but weakly, I accept, but significantly because we have lots of patients, to sputum eosinophils, but not to blood eosinophils. So what really matters is the eosinophils in the airways, not in the blood. We also looked at the we made 4 categories looking at our database based on blood and sputum eosinophils, and we distinguished a group with low blood, low sputum, low blood, high sputum, high blood, low sputum, and high blood, high sputum. And by doing that, by just reclassification of the patients, we were able to single out a group of patients which is really difficult to treat and will complain, that really single out from the other groups. This is the group with high blood and high sputum eosinophil count, with the chosen threshold of sputum eosinophil 3% and blood eosinophil 400 per microliters. Looking back at our database, we wanted to know whether if we take the patient longitudinally. So we looked back at our medical file. We identified patients that came twice, at least twice, at the asthma clinic and that had sputum induction plus the other test. And what we found by doing this analysis, the purpose was to look at the relationship between the symptom control, ACQ, and physiological variables. And what we found after sophisticated analysis was that there were 2 main variables that independently associate with the change in ACQ, so the change in the way patients perceive the disease. And these 2 variables were sputum eosinophils and FEV1, which makes sense and which is a bit reassuring. It means that when an asthmatic complains, actually it may complain because either there is a rise in inflammation or because there is a decrease in airway caliber. both factors influence significantly the way the patients feel. Looking now at the relationship between eosinophils and exacerbation, which is a key issue in the asthma field. And exacerbation is defined by the clinical situation in which the clinician judged that he has to give the patient oral corticosteroids or intramuscular or intravenous corticosteroids to take control of the disease. This is the definition of an exacerbation. And when we look at the exacerbation rate the year prior to the visit, we found that this group of patients with high blood eosinophil and high sputum eosinophils was clearly different from the other group with clearly a status what we call exacerbation-prone patient. And this was even more dramatic as a difference if you select the patients who are taking high dose of ICS and LABA. So those patients who are considered as severe asthmatics, uncontrolled despite the most effective treatment today as an inhalation. You see that there is clear difference between this group and the other group. So clearly, this is a group at risk of severe exacerbation, repeated severe exacerbation. This was a retrospective study. So there are also prospective studies looking at exacerbation and identifying a marker, risk marker of exacerbation. And once again, in this study, you see that sputum eosinophil count appears here. With an odds ratio through 3.27, this is clearly an important factor of exacerbation together with a high BMI, uncontrolled asthma, and to a lesser extent also a poor quality of life. Another study coming from Australia, interesting study, looking at patients with severe asthma. The previous one was a mix of mild to moderate and severe. This is only severe patients receiving high-dose ICS and LABA, and the patients were followed for 12 months. And once again, they found, and they were repeatedly sampled for sputum induction, and they found that those patients with persistently eosinophilic inflammation were those patients who exacerbate. So I think the link between the extent of eosinophilic inflammation and the poor asthma control and the exacerbation frequency, I think it's quite clear in the literature. What about the response to treatment, obviously, which is key? And this is the first study that actually sparkled the debate. This is a small letter published more than 20 years, almost 20 years ago, now in a Lancet by Jan Peverot, which has been pivotal in the work on sputum induction. And this is a study in which he just compared a group with eosinophils in the sputum versus without eosinophils in the sputum. They give the patients 6 weeks treatment with inhaled corticosteroids, and they assess the change in bronchial hyperresponsiveness, here measured by the PC20 value. And I think the difference is striking. You see that there is an improvement in bronchial hyperresponsiveness when you treat the patients with corticosteroids, but only in the patients with sputum eosinophil count greater than 3%. There is absolutely no effect if you select patients with eosinophilia less than 3%. I think it's a very important study. There have been lots of other studies going in the same way. And I just select this one, which is a very recent study, because in this study, they proposed an alternative to inhaled corticosteroids in those patients without eosinophilic inflammation. And it was an American study, multi-center study, comparing LAMA, so anticholinergic, long-acting anticholinergic, and inhaled corticosteroids in patients with repeatedly demonstrated non-eosinophilic asthma by sputum induction. They selected the patients who were twice with less than 2% in sputum, and then they compare the efficacy of mometazone versus tiotropium. And what they found, using a complex score evaluation, taking into account physiological variables like FEV1, symptoms, and also exacerbation, they found that LAMA was a bit more effective than inhaled corticosteroids in these patients. And here you see that using a biomarker probably may drive you to select your treatment in a disease, which is, I think, extremely important. This is one of the most important studies, I think, over the last 20 years, I believe, driven by Ian Pivot when he was in Leicester. And this is a study in which, this is really the study that established the value of induced sputum in managing asthma. This is a study in which they compare a management based just on symptoms or lung function versus a management, a monitoring of the disease based on measuring sputum eosinophils. And they adjust the dose of steroids based on sputum eosinophils in the group of sputum guidelines, while in a group of BTS guidelines, it was an adjustment of the dose of steroids based on symptoms and lung function, what every type of clinician usually do in clinics. And what I found is what the sputum guideline strategy was much better to reduce the exacerbation rate and to reduce the hospitalization. I think really pivotal study, unfortunately monocentric study, not replicated really in large multi-center study, but regarding the concept, a key study. And this is the study that drives us actually to implement that in our daily practice. And what we did in Liège since almost more than 20 years, well, 20 years, no, a bit less, sorry, in 2003, a bit less than 20 years, we do sputum induction in routine in our asthma clinics. And I wanted to know whether this concept of being eosinophilic was key in response to treatment. So we looked back in our database, and we found 100 patients who came twice, who had twice sputum induction, plus the other parameters, with change in the dose of ICS, initiation or increasing the dose. And we found 63 patients in which the dose was decreased, and 60 patients where the dose was not increased. But let's focus on this group of patients, 50 years of old. Half of the patients were atopic. Some of them were current smoker. Lots of them were ex-smoker. This is something which is important also in real clinical practice. 40% of the patients that you have smoking history. And all these patients are usually excluded from all the clinical study that serves to write the guidelines. So I think that's something you have to bear in mind. And what we found in this study was that those patients with high eosinophil count in the sputum, if you increase or initiate the dose of corticosteroids, you see that you have an impact on symptom, ACQ, on quality of life, on exacerbation rates, and also on FEV1. The time scale between the visit was variable. This was real life study. Usually the median value was between 1 and 1.5 years. So lots of things may happen between the two visits, obviously. But we just took notice from what the patient told us when they come to the clinics. I'm taking this drug at this dose. And then you write it down, and we compare the difference between the two visits. So it clearly shows that when you have a patient with an eosinophilic background, it's extremely useful to increase the dose of steroids. You can improve the clinical status of the patient. But if you have no eosinophils in the airway, there is absolutely no effect of increasing the dose of steroids in these patients. And even worse, if you look at some variables here, ACQ, the patient gets worse if there is an increase of steroids and if he has no eosinophilic inflammation. So sputum eosinophils, I think, is a very good biomarker. So can we approach sputum eosinophils by other biomarker? The first thing that pops in mind is blood eosinophil count, obviously. Yes, you can, but it's not perfect. But we derived a cutoff of 220 per microliter with decent sensitivity and specificity to approach sputum eosinophils. But we know also from our study there might be discordance between blood and sputum eosinophils. And if you sum up this group with high sputum and low blood, and this group with high blood and low sputum, which is rare, well, you end up with something like 1/3 of the patients in which there is a discordance between the blood and the airway. So what about FeNO, which has been a very popular method to approach in eosinophilic inflammation? This is one of our first studies looking at the relationship between FeNO and sputum eosinophils. The relationship is good, obviously, but you see here that there are some discrepancy from the point. And we identified by statistical analysis that there were 3 factors that really influence the relationship between sputum eosinophils and FeNO. These were smoking, atopic status, and the dose of ICS. So that you can see that the FeNO threshold that can predict an eosinophil count greater than 3% goes from 15 to 58. So it's a huge difference. According to the status of the patient, here 15 if this is a smoking patient without atopy treated by low dose of steroids, and 58 if this is an atopic patient without steroids and non-smoking patient. So you have to take in, if you want to use FeNO, you have to take into account these factors. So there is an excellent review by Korevaar in Amsterdam on looking at the different biomarkers that can approach sputum eosinophilia. This is, you can see all the results here. And you see the AUC from FeNO and blood eos are quite comparable. Serum IG is a bit less performant, clearly. You have here the different ROC curve showing what I just said. This is a good review. Based on this review, we had the idea, because there was no other study, we had the idea to try to combine these 3 better biomarkers. So IgE, blood eos, and FeNO. Looking back to our data, we did the analysis of almost 900 patients, and we derived from a combination of these 3 biomarkers some heat map. And when you have a dark color, red or blue, it means that you have a likelihood ratio that can tell you there is or there is no eosinophils. So by doing that, we were able to find that actually we can be sure that there is an eosinophilic status or not in 60% of our population, leaving obviously 40% of our population with uncertain eosinophilic status. So I think today the best biomarker that you can use in blood or in the airways, FeNO, cannot approach with sufficient accuracy the eosinophilic status in 40% of a population of asthmatics. So can be blood more relevant than sputum? That's another question. In severe asthma, because of the biotherapy, there is a renewed interest in blood because of this study showing that when you treat the patients with anti-IL-5, which is mepolizumab, very expensive treatment, 15,000 euro per year per patient, but very effective, but very expensive. And this study shows that the greater the blood eosinophil count at the baseline, the greater the impact of the drug, because you see that the difference between the treated patients and the non-treated patients is proportional to the extent, the magnitude of blood eosinophil counts. So because of this study, it has been a renewed interest in blood. And some people say, well, sputum is not valid. What really matters now is blood. I don't think it's true. And there is another study from the group of Nair in Canada looking at the impact of mepolizumab versus reslizumab. So these were patients treated with mepolizumab, but still having symptoms and uncontrolled disease. And after a washout of a few months, 1 year, they treat the patients with reslizumab, which is another anti-IL-5, but which is given intravenously, and you may titrate the dose according to the weight of the patients. What they found in this study is that mepolizumab was really able to decrease the blood eosinophil count, but not so much the sputum eosinophil count, and not so much to control the disease in this case. While when using reslizumab, you can not only control the blood, but also much better the sputum eosinophil count, and you improve the clinical status of the patients. Once again, pointing out the fact that it's what really matters to condition the clinical status of the patient, it's the airways and not the blood. The blood is a supplier for eosinophilic inflammation, but what really stick to the clinical status, that's the airways eosinophil. This is the change in FEV1 and ACQ that support the fact that the patients are getting better when you use reslizumab. In our database, because we have treated now more than 100 patients with mepolizumab, we wanted to know whether there were predictive factors of improvement in an objective variable, so FEV1. And what we found was that it was sputum eosinophils that predict the improvement in airway caliber when you treat the patients. Once again, and we didn't find a relationship for blood eosinophils. So what again supporting the fact that what really matters is sputum eosinophils. The more sputum eosinophils you get in your airways, the more dramatic improvement you see in your baseline airway caliber when you treat the patients with your drug over a period of 1 year. What about IgE? IgE, it is the other biotherapy in asthma, very expensive also, the same price of anti-IL-5, a little bit older. And if you look at anti-IgE, there is one biomarker which is often neglected, which is just IgE itself. But you can read the literature and everybody is writing IgE is not a good biomarker. I don't think it's true. Because if you look at these data, this is meta-analysis of the first study looking at anti-IgE, you see that the patients in which there is a more effect on reduction of exacerbation were those patients with IgE above 76. All these studies were conducted in patients with IgE between 30 and 700, but you see that the main effect, if you want to reduce exacerbation rate, was the patients in whom IgE was about 76. And if you want to concentrate on an improvement in airway caliber, it's the patients with IgE above 274. So, and it makes sense because you are targeting IgE, so it's logical to think that you will be more efficient if the patient has IgE. But I don't know why, but if you read the literature, everybody is writing IgE is not a good biomarker. It's not entirely true to me. This is a real-life study coming from France in which apparently, because there was one other study from America saying, well, IgE is not a good biomarker. What really matters is FeNO, EOS, and Eosinophils and periostin. And in this study, which is a real-life study with all the, obviously, the drawback of retrospective study, large-scale study, they didn't find any predictive value of the response to IgE, so they scratched everything down. EOS, IgE, periostin, everything was non-predictive of the response to anti-IgE, and the response was defined by a 40% decrease in exacerbation. So I think real life is sometimes very different from clinical control study. And one thing that we did, this is a small review from my town in French, but what we wanted to do in this study, we made a survey on chest physician and on GP to ask them, what do you consider as a clinical criteria to push you to prescribe oral corticosteroids to a patient? Because that's the definition. That's the definition of an exacerbation. And what we came out from this study, this is a survey on something like 30, there were I think 16 chest physicians and between 20 and 30 GPs, small study, so it's the reason why we write it in a local journal. But I think the message is important probably. There is a wide variation in the clinical parameters which trigger the prescription of OCS in asthmatics among chest physicians and among GP alike. So what we consider as a gold standard, the exacerbation rate, is something which is subjected to high subjective perception and behavior of the physician, which is, I think, a key message also. So in our asthma clinic, we also looked at the predictive factor of response to omalizumab, and we found here it was not eosinophils, but it was baseline FeNO. So if you have a high FeNO at baseline, you have an improvement in your symptoms in ACQ regarding the treatment with anti-IgE. And now I come to the last part, but I'm not an expert, I'm not a chemist, I feel a bit outlier here. You know that better than me. So we undertook a study looking with the goal to try to identify VOX that can identify patients with eosinophilic versus neutrophilic inflammation, because I believe it's key in clinics, because it must drive, in principle, your treatment. And we did a study on a discovery cohort and then a replication cohort. This is the scheme of the study. This is the baseline characteristic of the patients. We had a cohort of the discovery of 276 and then the validation cohort 245. You can see that I told you about smoking, for instance. Smokers, it's something like between 15 and 20%, and ex-smoker 35. So that's the real life, that's reality. So if you want to just focus on non-smoking asthmatics, you are losing almost half of the patients that you see in clinics. These patients had, well, this is the classical feature, FeNO, blood ears count, and the baseline FEV1 value was 85% predicted. I think it's a large mix of mild to moderate and severe asthmatics. And what we found, this is the summary of the study. This is the comparison between eosinophilic disease and non-eosinophilic disease. We found two biomarkers, which were hexane and 2-hexanone, which were able to discriminate between eosinophilic inflammation and non-eosinophilic inflammation with an accuracy similar to FeNO and blood eosinophil count, you see. Almost the same value of AUC. But if you combine these three things, FeNO, blood eos, and VOX, you increased your accuracy to almost 0.9, which is, I think, quite satisfactory. And we also looked at the neutrophilic inflammation, because there was no data in literature supporting any biomarker to identify neutrophilic inflammation. And we found 3 biomarkers, nonanal, hexane, and 1 propanol, as being able to, with an accuracy which is less strong than the combination for eosinophilic inflammation, but still not too bad, 0.7, to identify neutrophilic inflammation. Yes, that's finished. Take-home message, yeah. Sputum eosinophils is a reliable biomarker predicting the response to ICS that can only be approached in 60% by combining proxy. The technique of induced sputum should be implemented in any severe asthma clinic, I think. FeNO is a user-friendly biomarker which may help diagnosing and predicting ICS responsiveness in mild to moderate asthma, but less suitable to manage severe asthma because of lots of confounding biomarker. Blood is not necessarily the best compartment to choose biomarker to predict response to biologics, in contrast to what is currently said. And there is potential in measuring VOX in exhale air to phenotype and monitor asthma. Not to diagnose of asthma, I just discussed that with one of my colleagues, not to diagnose asthma, but to monitor and manage asthma. Because I think that the diagnosis of asthma is something which is linked to lung function abnormalities. We are not going to change that, apart if we change the definition of the disease. But I think diagnosis is something which is linked to lung function, and we have to do lung function, and then we have to manage and monitor the disease. And in this case, I think that measuring VOX may be useful. Thank you for your attention.
Thank you very much.
Great.
Could the problem of getting less significant results from blood be related to which blood they're testing? Are these studies mostly looking at venous or arterial? And has anyone looked at both? I would imagine the eosinophil count might be different.
I'm not aware of any study comparing arterial and venous. I don't know. It's always venous. Obviously. But I'm not aware of any studies comparing. We compare blood arterial gases between arterial and venous, but I'm not aware about any study looking at blood cell count in arterial and venous. No.
Do we think the eosinophils got in the blood from the lung, or that they were brought to the lung from somewhere else?
No, I think the eosinophils are brought to the blood from the bone marrow, and then they go to the airways. It's my perception of things. And this is the reason, this is the mechanism through which anti-IL-5 acts. I think they are drying, if you want, the supply by decreasing the blood eos count, by acting in bone marrow. And so there are a very limited number of blood eos, so there are much less eos in the airways. I think that's the mechanism through which anti-IL-5 acts, I believe. Yeah.
Thank you. Time for one more question. Greg in the back.
Thanks, Professor. Great talk. Really interesting stuff. I know a number of years ago, you and your group looked at isolated eosinophils and neutrophils in vitro, and the VOCs thrown off by the isolated cells, looking at the headspace. So if you go back to that data, do you see the same VOC?
Not at all, yes. Well, thank you for the question. I could have also put some slide with that. This is a study which was undertaken in Frédéric Jan from Maastricht. He's here. So, and the whole study was done in collaboration with Maastricht and the chemistry department from Liège. That's, I think the chemist and the toxicologist were key, obviously. But that's an interesting question. The compound that were identified in purified eosinophils or neutrophils in vitro were completely different from the one in vivo. Once more, highlighting the fact that it has been said by somebody in the previous talk that breast in vivo is a very complex milieu. And you cannot deduce what you are going to find in breast from in vitro analysis with purified cells. I don't believe it's.
Thank you very much.
Thank you.